And treatment, Depo is pretty good. Birth control, just regular oral birth control pills work. And then last resort would always be surgery. PCOS, that is a complex endocrine disorder. The ovary could look like that polycystic string of pearls, or it could not. But you'll find a lot of women having problems with androgen excess, with the facial hair, the hirsutism, increased muscle mass, deepening voice. Infertility is a big one. Periods are very irregular if they have periods at all. And we talked about treatment with those, birth control pill, metformin, Clomid if you're trying to get pregnant, Clomid with metformin if you're really trying to get pregnant. And then menopause, not having a period for a full year. And we talked about some manifestations with those. Talked about some surgical interventions like DNC, ablation, and then as reporting them to the local health authorities. Syphilis has 4 true stages. We have primary, which is the canker sore. We have secondary, which is the rash and the flu-like symptoms. And then we can have early latent, late latent, where it's still in the body, still causing problems, but not necessarily, you don't really have some of the symptoms. Could have the rash again, but it just depends. And then tertiary is the final stage. And again, it's already in the body. It's wreaked havoc on the body. It's done its damage. So a lot of times it's symptom support there. We talked about treatment. So then herpes, we said there's herpes simplex 1 and there's herpes simplex 2. Neither one of them you can cure. It kind of stays dormant. And then until you have a trigger. And we talked about some of those triggers. There are treatment options, those antivirals. There can be PO, there's creams, and of course there's IV. If the outbreak's really bad, they'll be admitted and put on IV therapy, IV antivirals. We talked about how painful it was, especially when it first breaks out. That initial breakout is very, very painful. And we talked about how it can cause long-term complications, can cause cervical cancer. It is transmitted to the neonate and puts you at higher risk for other infections, especially HIV, because we have those open areas. Genital warts. So that's caused by HPV. We said there were over 100 types. What they look like, they're initially flesh color, they're small, and then they grow into like cauliflower-like mass. And that if you touch them, mess with them, they tend to bleed. So we got to make sure we tell them keep stuff clean and dry as much as possible, because we don't want to introduce more infection. Medications, you have a slide on that. Gonorrhea, we talked about silent infections transmitted by direct sexual contact with mucosal surfaces. You guys have a good slide on that. We said gonorrhea and chlamydia are like sister infections. So a lot of times when you diagnosed with gonorrhea, they will treat you for chlamydia too, and vice versa. So they'll a lot of times do that combo therapy, which is that cephalosporin with that Zithromax or Doxy. And we have that picture of that baby that has that neonatal conjunctivitis. We said all babies born, however, will always get that the erythromycin cream on their eye to prevent that neonatal conjunctivitis, because it's not just gonorrhea that can cause that. It can be caused by the mom's natural flora as well. So all babies get it no matter what. Chlamydia, let's see. Talked about the symptoms. Chlamydia is the, when it comes to STIs, is number one for PID, causes PID. And then that leads us into PID. So PID, we had that, remember that big umbrella that had salpingitis, which is the fallopian tubes, oophorytis, which is the ovaries. It can cause tubal abscesses, parametritis, peritonitis, and endometritis. So that big umbrella term. And where does it like to go the most? Where is the most common location? Anybody remember?
Fallopian tubes.
Fallopian tubes. And what can it do to the fallopian tubes?
Cause infertility.
Yep. Cause infertility. It can cause scarring. Can cause infertility. It can cause ectopic pregnancies. So it's a big deal. And treatment is going to depend on what organism it is. Mm-hmm. So when they do the cultures and whatnot, they will determine how to treat it. Remember, these females, they're very sick, fever, malaise, hunched over, they are sick. All right. Pull up my slides. Give me just a second. We'll pull up.
Can I ask you a question really quick before we get into childhood women, please?
Sure.
About the PCOS, the Clomid. So did you say if you're trying to get pregnant, you can take Clomid, but if you're really trying to get pregnant, you can take both Clomid and metformin? Is that correct?
Yeah. So what they'll do is if you're trying to get pregnant, they will do Clomid first for one cycle. And if that does not work, then they'll add Clomid with the metformin.
Okay, thank you.
And sometimes some doctors would just go ahead and do both just to take care of it. But it just really depends. All doctors are different. But metformin helps you ovulate. Clomid helps you ovulate. So we got two good drugs for that. All right. Mm-hmm. They can, and I've known them to. I've heard cases that they will try both with infertility issues. But the thing about metformin is you have to be careful. It is it does help lower your blood sugar. So somebody that does not have diabetes or has issues with their sugar, do you think that can cause hypoglycemia?
Yes.
Absolutely. So it has been used. I've read about a few cases, but there were rare cases, and they did a lot of teaching with hypoglycemic and nutrition as well. So I've only read about or seen, I guess I shouldn't say seen, I would say read about probably 3 or 4 cases when they did that. Mm-hmm. All right. Let me on the screen. Start recording. You guys go ahead and mute yourselves unless you have any more questions. Record. All right. So we started a little bit on this guy right here. Growth and development, we said, oh, you know what? That's not what I want to do. Sorry, guys. I already had this saved somewhere that we were taking notes on. That's the one I want to do. All right, there we go. It's a whole bunch of crap to get to this stupid screen. Yes, this is what I wanted to share. Record. Okay, good. All right, so we said that when people talk about growth and development, they kind of mix those terms together, but they are separate. So growth is the measurements. Growth is the height, the weight, the head circumference. So those are actual numbers. Whereas development, guys, please mute yourselves.
I'll just leave it and you
There we-
you'll be getting back in it.
Did y'all mute? Okay. Whereas development is the milestone. So are they sitting by 6, 7 months? Are they walking by 12, 13, 14 months? Are they able to hold a spoon? So development is that term. Okay. Are they meeting those milestones? So here are theorists. Here's my boyfriend, Mr. Erickson. So with infants, so we got birth to 1 year. We said that their play is solitary. They manipulate things. So when they're sitting in their seat or on the floor or whatnot, they're just kind of playing with things. And then eventually they'll start putting things in their mouth. So you have to watch out for that. They communicate by crying, by making sounds, and vital signs. So if they have a really high heart rate or the respiration rate, things like that, they're talking to us. We need to listen to those things. And then for Erickson, we talked about his birth to 18 months. So trust versus mistrust. So when those infants do cry, are they trusting us to respond to that cry? And so I think you get into a big can of worms when we talk about ferberization. You guys ever heard about ferberizing? Anybody know what that is?
No, I don't.
No.
You've ever heard of let them cry?
Oh, yeah, I do that
Oh,
all the
yeah.
time.
Yep, that's ferberizing.
Okay.
So put them in the crib, make sure they're not hungry, make sure they're dry, make sure they're warmer, not too hot. Put them in the crib and let them cry themselves to sleep.
Mhm. It works.
And I personally don't like that because then, I can't sleep. My nerves get worked up. But ferberizing, they're saying they're making the baby soothe themselves. There's nothing wrong with them. They just want the attention. But then, I don't like to be left alone. I get lonely, right? So why doesn't a baby get lonely? The baby spends 9 months in your belly hearing you, for 9 months, and all of a sudden they don't hear you. So why do they not get lonely? That's just my opinion. You guys look it up. I'm not touching that. All right, toddler. So this is my son. When he's probably about 2, right at 2 years, maybe 2.5. But so toddler, which is my favorite time for kids. I love a toddler. They're the sweetest. At the same time, they're the meanest, but I love it. So cognition, so, they're moving from the sensory motor to the pre-operational. You guys know about that. They're using early language. They are solving very basic problems, right? So I'm going to say rudimentary problems. And so I have this picture. My son has been a problem solver since day one. He can figure out how to solve a problem. And so we redid his room, we painted his room, and we just put up this little shelf right here. And he wanted to get a picture of it for his grandma. And he said, Mom, I can't see it. I said, oh, you can't see it. And next thing you know, he's grabbing the ladder, right? And so that's just an example of a simple problem solver, right? And so, a couple months later, he's trying to pull up this heavy thing, his treasure chest on top of his playground, or where the slide is, so it was elevated, and he couldn't use 2 hands to get up there. So he had to climb up there. So he creates a pulley system, wraps it around the treasure chest, and is pulling it up. And he's not even 3 years old. And I'm thinking, my gosh, you don't get that from me. Anyway, he's always been a really good problem solver. Communication. So they're speaking about 1,000 words right now. 1,000 words. They use sentences, but they're short sentences. A lot in toddlers, they do parallel play. Y'all know what that is, right?
Yeah, they play by themselves in like a group.
Yep. So they're all playing with kind of different toys, but they're playing by themselves, like you said, but still kind of within the group. So their best friend might be playing beside them, but the best friend is playing with a puzzle and they're playing with something else. So they don't want to be isolated by themselves, but they still want to play by themselves, if that makes sense. So playing by themselves, but within a group. And then Erikson, where are we in Erikson? Anybody remember?
Autonomy versus shame and doubt.
Yep. Autonomy versus shame and doubt. So think about a toddler. One of the biggest milestones for them is toilet training, right?
Yeah.
So as a toddler, as a young child, a toddler, we pretty much as parents tell them when to eat, what to eat, when to go to bed, what time to wake up, and to the point what to wear. I always let my kids kind of choose their own wardrobe, but to the point what to wear. So what is the one thing they control?
Their bowels.
That's right, their bowels. That's the one thing they control. And so that's why we have the autonomy issue right there, because that's the one thing that they can control. They want that sense of independence. So they need that personal control over their physical skills. So.
And this is where they like to say no all the time too.
Yes. No. Can I help you put your shoes on? No. Can I brush your hair? No. So. All right. Preschool. This is my son. So I do have pictures of my daughter. I just don't have them on my phone when she was a toddler because I didn't have that phone back then. So I do love my daughter. Don't think I play favorites. Gosh, y'all probably thinking that. This is my son, again, so he's a preschooler. I think this was his 4th birthday, maybe. It's got to be. And it's a monster truck. He loved monster trucks back then. So preschooler is about 3 to 6 years, thereabouts. They begin to use symbols or words to represent objects, which is a good thing. So we kind of know, kind of figure out what they're thinking a little bit. Their play, they do associative play, and they interact with others. You will still see them doing a lot of parallel play at that time, but you will gradually see them start to interact more with those others, especially girls. Boys, I saw my son was interacting more with other boys when they played sports together. So we have a neighbor down the road. They started playing very early on together in their yard. So since they do associative play, since they have that associative thinking, as nurses, guys, we can let them play with safe medical equipment, right?
Yeah, like a stethoscope.
Mm-hmm. Not a needle, right?
Well, no, yeah. Stethoscope.
That's not safe.
Stethoscope.
So a lot of times my kid's pediatrician still thinks they like to play with those tongue depressors. I don't know why, they're old enough, but he still gets those tongue depressors and say, hey, you want to play with these? Sometimes they'll give them little cotton balls or I don't know, just something. It's nice if they're in the hospital and they're going to have surgery or something like that. You can actually get a doll and kind of show them what's going to happen, but in words that they understand, of course, right? You don't say, we're going to cut you 5 inches. No. Words they understand and they're not going to freak out about. Communication-wise, so they're talking about 2,000 words. Their vocabulary is growing. They're talking more incomplete, and sometimes even complex sentences, depending on what's going on. However, they are very literal, guys. So you have to be careful. Did I spell that right? Maybe. Okay. You have to be careful. If you say it's raining cats and dogs, guess what they're going to think?
It's literally raining cats and dogs.
Right. And so my favorite story, I think I've told you this before. We were reading about an article, a newspaper article that says backyard chickens cause salmonella. And my son looks at me and says, can we put them in the front yard? I mean, so very, very literal. Problem solver, right? Yeah, let's just put them in the front yard. Take care of it. And so where are we at with Erikson?
Is this identity?
Not quite.
Okay. It's autonomy.
This is initiative versus guilt.
Initiative versus guilt. Guys, I do have a Erikson chart for you that I gave you guys in 111. So please look at that. It's just a quick Erikson snapshot. So please look at those, okay? All right, here's my daughter. So this is,
I wasn't in 111. Maybe someone else has a quick snapshot of it other than what you've
it's on Blackboard. It's on Blackboard. I was just telling them that I used the same one for 111. It's the same one. Yeah, but it's on your Blackboard post. School age. So this is about 6 to 12 years, and my daughter was probably about 11-ish in this, and she's still nothing but legs to this day. I don't know when she's going to grow elsewhere, but her legs, but still. So 6 to 12. So now we're definitely concrete operational thought, right? They are good. They are, I'm gonna say, better problem solvers. They can solve more complex problems than they did when they were younger. They can certainly carry on a conversation. Okay, they still may be shy when talking to new people, but they can certainly carry on a conversation if they need to. So they are cooperative play. Oh, that has too many zeros. Cooperative play. So now they like to play in a group. They like to, form these little girly clubs. Guess who I like? So-and-so likes so-and-so. They're in that type of the mentality. Right. Communication, when you look at their schooling, they are learning the parts of speech. They are writing in school, writing essays, journals, things like that. And I'm going to put on here social media. That is a big, 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 big thing. And I think you will see more and more people that do not know how to communicate because of social media, because of texting, like that. There's a thing on Netflix. Those my Netflix people out there calls The Social Dilemma. Just watch that when you don't feel like watching anything else. Erikson, where are we?
Identity versus role confusion.
Not quite.
Oh.
Almost there.
Oh my God, trying to remember without looking.
Industry versus security.
Yes, industry versus inferiority.
There we go. Cool.
The kids, you have to think about the kids a little bit. I know the babies and the toddlers really good, but when I get to the preschool school age, I tend to get those flips. I have to think about their milestones, and when I think about those milestones, and they click. All right, so here we have a sense of competence. They want to do well in school. If they don't do well in school, then they kind of lean toward that inferiority complex, right? So this is my daughter all day long when she was school age. Even now as a teenager, she wants to do well in school. My son can care less. He is 11 years old, and I don't know where he is. He doesn't really meet any of these criteria for me. So this is Grace. Again, we were at the Panthers game last year. She was 13 at this time. She's 14 now. So it depends on your book. So about 13 to 18. Some books say 12 to 19. I'm not going to split hairs on that, okay? when I think of teenager, I think of teenagers, 13, 14, 15, 16, and 19, but I'm not splitting hairs. So they are in the formal operational thought. They can reason and think abstractly. My daughter didn't tell her I said that. I'm just kidding. I love her. I always call her, I look at her, she'll say some stuff and I was like, gosh, I'm so glad you're pretty. She knows it too. I'm just kidding. We just give her a hard time. And reason independently for sure. So they're able to think more independently, abstract think, reason abstractly. So they're good to go. So when it comes to their play, they don't really play when we think about groups and things like that. So who means the most to a teenager? Is it grandma?
Their friends.
Peers.
Peers. They want to be with their peers, right?
Mm-hmm.
They're probably very involved in sports or some kind of activity. You know, for her, she does dance and cheerleading. So she's big into that. Right now she's 14. She's thinking about driver's ed, right?
Video games.
Yep. She's not into video games by much, but for sure video games. And then of course, when you get that age, they kind of get like more rated MA type thing. They want to play more of the mature video games.
Mm-hmm.
So you have to kind of monitor that. Communication, slang, meaning stuff that they hear on Fortnite and whatever. They'll come back and they'll say something they heard on a YouTuber, and I'm like, what? Like, oh, so and so says that. And I'm like, who was that? You know. So they'll pick up those slang terms. All right, Tracy, where are we with Erickson?
Identity versus role confusion.
Yes. we got here. So they are developing a sense of self. Who are they? So my daughter talks to me a lot about her future, even at this point. You know, she's like, Mom, I don't know what I want to be when I grow up. And I said, that's fine. You have plenty of time to think about it. You know, don't feel like you really like this thing and you have to stick with it. And now's the time to figure out who you are and what you like. So that's what I say to her. You know, she really likes animals. I'm thinking, well, maybe you want to go into the animal route. She loves horses. So I'm thinking, well, you know, I can't afford a horse, but we know people who have horses. So anyway, she's got plenty of time to figure it out. Don't rush it. Oh, I want to say yes. So adults. So with adults, we have intimacy versus isolation. My splitting hairs was about 19 to 40 years old. It's different books say different things, but we're in that intimacy versus isolation. So here in this age group, we are trying to form intimate relationships, or just relationships in general. It doesn't necessarily have to be a spouse, just some kind of relationship that's lasting, or you risk isolation.
So just like a meaningful relationship. Is that
Yeah, yeah, it could be a close friend. I got a next slide that kind of says that too.
Cool.
So, and then the generativity versus stagnation. So we're about 40, 65 years old. And so with them, not just generation, but with this age group, they strive to create or nurture things that outlast them. Okay, so a lot of times they'll talk about the environment. They want to have a good environment for the future generations, right? So that's just one example. All right, so this is me and my husband.
Mm.
I know, right? This is when I was about 15 pounds lighter. COVID has not been pretty at this house. But anyway, young adults to marry, not to marry, that is the question. So they develop relationships with the spouse, family, or friends that are rewarding. So like I said, it doesn't have to be necessarily a spouse, just something that's rewarding. Or risk isolation. And so in this time period, that 19 to 40 age group, They worry about exercise, diet, stress, and health. And I have to say that I'm in that age group. I have to agree. I try to try to exercise. I try to eat right. Stress, I try. I mean, we all know how that is. And then health. I'm not very good with my health though, because I do get like my annual stuff done. I go to the dentist, but I don't see my regular PCP like I should. I ain't got time for it really, but anyway, I need to make time for myself, right?
Yeah.
All right, middle adults. So that was the 40 to 65-ish group. So productive and creative, they're concerned for future generations, or they can become self-absorbed. We know people who are like that. This is just a quick YouTube video. It's nothing important. You guys can watch that on your own. So they worry about empty nest. So this is the time period where the kids are grown and they moved out of the house. Hopefully that's what I want, at least. My kids, I want them to be nearby, but I want my house back. But they worry about empty nest. Sandwich generation, do you remember what that was?
Is that where everybody like stays together?
Not quite.
Okay. I'm not sure.
Right. And so I'm not considered a middle adult just yet. I got a couple more years, but my mom is to the point where I have to kind of check on her. Mom, do you have your appointment? Are you going to your appointment? I don't have to care for her right now, but with her decline in health, I could probably see that soon. And then I still have kids at home. So I'm kind of like the meat of the sandwich. I'm caring for my mom and I'm caring for my kids who still need me. Okay.
Yeah.
And that can be very stressful. I know some of you guys have probably been there, done that, and you know how stressful that is. And then we have lifestyle choices that affect their health. So I'm talking about lifestyle choices when they were younger. So if they were younger, their teenage years, or young adults, and they did a lot of drugs, drank a lot of alcohol, had a terrible diet, that can certainly start playing into their health when they hit middle adults. Okay. All right. Older adults. Which I love older adults too. Do you remember when? So I just have that quote there because they love to talk about the past. You know, when you have a patient that's older, do you remember when this happened? Or do you remember? And a lot of times I'm like, no, I wasn't born. You know, I wasn't alive then. But anyway. Accepting one's life so far, reflecting on it positively, or they feel that one's life has been lived in vain. So they want to kind of like leave that legacy, saying, did I live a good life? Did I do good things for people? Did I do good things in my life? They worry about decreasing physical ability, being alone, losing a sense of control, and of course, chronic health concerns. So, you know, in this, where are we in Erickson real quick? Anybody remember?
Death versus despair.
Integrity versus
integrity. Okay.
Integrity versus despair. So integrity meaning reflecting on their life positively versus despair, living that life in vain. So other health concerns, guys, we talked about chronic, but you know, they are at risk for falls, hearing and vision loss, you know, they cataracts, other vision things that are going on, heart disease, lung disease, osteoporosis. I mean, we can keep going, right?
Mm-hmm.
Yes. So I'm going to, let's see, I'm going to make this bigger first. So this is just one of these slides that sometimes our drug reps give us. They give us like these little books and have these little cartoons in it. But special considerations for older adults, they have a decreased tolerance to meds. So you might have somebody that's 25 years old that can take morphine 2 milligrams like a champ, but then you give it to mama who's, 80 years old. She can't take that 2 milligrams of morphine. We really sedated her. So you got to be aware of that. They're at risk for fluid overload. So again, we have to worry about how our rate is for our IV. Risk of respiratory depression, pneumonia, disorientation, skin breakdown, pause of circulation, nutrition, constipation, fluid electrolyte imbalance, incidents with falls. If they get suddenly confused, which a lot of them sometimes do, a lot of times it's going to be quick check their oxygen saturation level. A lot of times it's dropped, and if it drops a little bit, they can be confused. Another thing check for is a urinary tract infection, a UTI. They'll get really confused with that. And of course, electrolyte imbalances. There are other things. Those are just quick checks we can do. Call the physician and say, hey, Mrs. Smith, all of a sudden she was alert and orient this morning. Now she's confused. I checked her saturation level. It's 98%. But I do know that her urine was cloudy last time. Quick check, UTI. So, and then we're back in business. I have notes for you guys with this thing. You guys can read about it. Let me make sure there's nothing I want to point out though. So skeletal, look, the spine guys, they have a loss of height each year. And that's due to, so you have a spine, it's nice elongated when you're younger, but as you're older, you have like compression fractures. And so you'll actually lose height. That's why if you think about your grandma, when you were younger, she was much taller than she is now because they do lose height.
Kyphosis is the hunchback, right?
Kyphosis is the hunchback, and then lordosis is the swayback, like a pregnant woman.
Pregnant, yeah.
Skin-wise, we have loss of elasticity. Remember when we assess the tenting in the hands or the sternum, their skin is not elastic, so we can't really do the hand. That's not a good indicator because it's going to stay up, right? Because they don't have that elasticity anymore. So GI, constipation, digestion is slow. They don't have a good gag reflex anymore. So we definitely don't want them to develop aspiration pneumonia. So we watch out for that. Sleep and rest. They don't sleep long at one time, but they do nap often. So as an inpatient, again, they're not going to sleep at night, but let them nap during the day. Okay, give them a chance to nap during the day if you can. And sometimes we're monitoring every 15 minutes. So they don't get a nap, sorry. But if you're able to let them nap, then let them nap. And they take little short naps. Nothing like a bear hibernating. So we said after menopause, we have a decrease of estrogen. With the decrease of estrogen, we can certainly develop osteoporosis. So there's that kyphosis, the hunchback, and then we have the lordosis with the swayback. Let's see. Slender female Caucasian alcohol users, smokers, and steroid users are at highest risk. All right, so this is the 5 A's of Alzheimer's, anomia, inability to remember names of things. This is me. I can't remember my dog's name and my kids' names hardly ever. I just call them all at one time. Apraxia, misuse of objects because of failure to identify them. So this particular patient says, why doesn't this pen work? And she's using her shoe. And so a lot of times you will see persons with Alzheimer's, some of the earlier stages where their family members are kind of like cluing in, is that they'll put stuff in the refrigerator that doesn't belong in the refrigerator. They'll put stuff in the wash machine that doesn't belong in the wash machine. So those are kind of like, all right, what's going on, right? Agnosia or nausea, inability to recognize familiar objects, taste, sounds, and other sensations. Amnesia and aphasia, inability to express oneself through speech. So I can't say the right word. So a lot of times this can be frustrating because they they know what they kind of want to say, but they can't express it. So it kind of gets stuck. And that's very frustrating. Sundowning. So another thing that happens to your elderly patients is the closer it gets to evening when the sun is coming down, the more confused and agitated that they become. And this happens. I used to work night shift, and I would get report from the day shift nurse, oh, she's so sweet. She's the sweetest thing you've ever seen. And I'm thinking, great, I'm going to have a great night. And I go in there, and she's hanging from the blinds. I'm thinking, what is going on? So obviously, she was affected by sundowning. So it's a real thing. And those who work night shift, y'all know. Senile dementia. Let's see. I don't think there's anything I wanted to add there. No, this is just a little device to assess for senile dementia. Nothing really there. All right, cataracts. So as we get older, older people develop cataracts, and it's a cloudy, opaque lens. And so as it progresses, so it does progress. So it's not like you wake up one morning and you can't see. It's a progression of the cataracts. And so you can't see, decrease acuity. It doesn't hurt. And treatment, they remove the lens and replace it. So they do like a little, like a transplant. So I like cataract surgery because I used to prep patients for surgery for cataract, and it's really neat. You know, they do lots of different eye drops to prepare the eyes, and it's an amazing thing. I'll see them sometimes after surgery, and they're like, I can see. Miss Beaver had it done not too long ago herself, and they don't do both eyes at the same time. Obviously, they don't want to operate on both eyes at the same time, and then you can't see at all because of your shield, but they'll do one at a time. But Miss Beaver had hers done. I think she had a left eye done first. And she came back to work, and you could see her eye just so clear and so beautiful blue color. And then you could definitely tell the other eye was definitely cloudy. And so she got that one done about 6 weeks later. So anyway, but when you first develop cataracts, they don't do surgery right away. What they'll do is they'll try like corrective lenses, things like that. And then as it progresses, they'll do surgery. One big thing about cataracts, though, is they don't like driving at night because there's a big glare. And so if you think about driving at night, all these lights around, the cars are coming at you, the street lights, everything is just kind of like a big glare to them. So safety can be an issue with patients with cataracts. But like I said, they'll try progressive lens or corrective lenses first, and then as it progresses, they'll do surgery. So it's a very fast surgery. I'm talking about they are in and out probably in about 20 minutes. It's crazy. All right. Some more.
Ms. Atkinson.
Mm-hmm.
During my OR rotation, a lady had cataract surgery or procedure or whatever, and from start to finish, it was literally 15 minutes. It was crazy.
It's crazy. It's crazy. And so the biggest thing, like, you know, for me was the prep. You know, it took a while to prep because you had to wait a certain amount of time to put this next eye drop in. But I mean, they're in and out. And guys, I got something in my eye right now. I don't know what it is, and it's freaking me out. And I'm gonna have to call somebody to come get it out of my eye. So now that I can feel it, before I couldn't feel it, I could just see it, and now I can feel it and it won't come out. And I don't have vision insurance, so I don't know what to do. So if y'all have know any people that can help me, please help me. All right. So conjunctivitis. Conjunctivitis, you'll hear a lot of times people call it pink eye. And it can be bacterial, so it can be some creepy crawlies. So I have Staph aureus and Haemophilus influenzae right here. So that can be some of your bacteria issues. It can be viral. So adenovirus, which is like the common cold. And I have herpes right here. It can be allergies can cause that conjunctivitis or that conjunctiva to be red. You have intense itching, the red eyes, the watery discharge, and then I have irritants. So think about it. If somebody were to spray you with mace, do you think your eye will be red?
Yes.
Yes.
Absolutely.
Yes. If you get soap in your eyes, chemical spray, stuff like that, then yes, that can cause your conjunctiva to be inflamed. So conjunctivitis, inflammation, the conjunctiva, which is that thin mucous membrane that lines the inner aspect of the eyelids and interior surface of the eyeball. So let's see, some manifestations. So it really is going to depend on how you got it. So if it's like a chemical or allergies, it might just be red, some tearing, right? But if it's bacterial, viral, you might have some of that purulent exudate, along with the tearing, along with the crusting, along with the itching. And sometimes, guys, I'm talking about kids here. We're doing kids. But, they'll wake up in the morning and their eye is glued shut from that discharge, right? So you have to they would open their eye, don't want to touch their eye because it's easily spread. And you kind of have to take a warm washcloth and just kind of scrape that stuff out of their eye. So it can be quite gunky. Just some pictures. We got that bloodshot appearance right here. Right here, we have that yellowish discharge coming out of the eye. So treatment, the bacterial kind, guys, is highly contagious. And oftentimes, if you get it in that right eye, you're going to get it in that left eye because it's just so easily spread. It spreads in daycares like wildfire, okay? So that's why if your kid does have conjunctivitis, the bacterial kind, they are going to say you cannot come back to daycare or come back to school unless you've been on antibiotic for 24 hours. So 24 hours is that window. So treatment, removing the crust, like I said, just get a warm washcloth, remove it from the inner to the outer canthus. Get another side of the washcloth. You don't want to use that same side of the washcloth every time you're wiping. So turn the other corner, inner to outer, turn the other corner, inner to outer. You'll learn that when you guys learn how to do a newborn bath. You always go inner to outer with the new corner of the washcloth each time. If it's bacterial, of course, we're going to need some antibiotic drops or antibiotic ointment. Avoid rubbing, because if I rub this, then I rub this, guess what? I just spread it, right? So easily too. If it's viral conjunctivitis, if it's caused by that cold virus, basically there's nothing you can do about it. You can just do like symptom management. We do warm compresses, just because it's kind of itchy, it might burn. Warm compresses, and usually if it's just that cold that's causing the redness, it's self-eliminating. You just kind of wait and see game. Every time my kids get a cold, they always get, their eye gets red every time, never fails. And the reason why I know it's viral is because the next day, that eye's much better, but then the other eye is red. So, and then the next day, they're both completely clear. So that's how I know it's viral, because it just kind of goes away on its own. If it's bacterial, we will need antibiotics. And a lot of times they'll use fluoroquinolones, eye drops for that. Sometimes not. Let me see if I can spell fluoroquinolone. I can't. They're frequently used. There's other ones, but that's just an example. If it's allergies, what do we do?
Visine?
Yeah. There's stuff out there. There's antihistamines. There's eye drops just for allergies. Whatever. Sometimes cool compresses can help with that. Whatever.
Visine isn't really good to use though. You should use like just an allergy kind of drop. The Visine also gives you like a rebound effect, where if you use it, your eye's going to keep getting redder and redder and redder, and like twice as red on the way out.
I heard that. Yeah, I've heard about that.
So I was
Come through with your background, Jamie. Come through with your background.
Oh, that's right. Jamie's on here.
Yeah.
Just make her the host.
I'm so back
No, it's okay.
All right. So if it's chemicals, soap, whatnot, what do we do?
Rinse your eye out.
Yeah, it depends on what's in your eye. Let's say if you get Clorox in your eye or whatnot, they say call the poison control, right? And a lot of times when it's something like that, they'll say flush your eye with water, cool water. Sometimes if it's something crazy, they might say emergency department, whatever. But usually it's just flush your eye out with cool water. I don't know what to do with mace. I guess you just sit there and wait a little bit. I don't know. I'm assuming flush. Go ahead.
No, I was gonna say sometimes with mace they say milk helps.
I was gonna say milk, yeah.
I've heard that before.
Baby shampoo helps.
Oh, baby shampoo. Okay. All right. All right. Let me see if there's anything else I want to add about conjunctivitis. No, I think we're good there. All right. Otitis media. So inflammation of the middle ear. Most common will be affected between 6 and 36 months. And that is because a couple of things. They have a dysfunction of the eustachian tube. So eustachian tube runs from that ear down to that nasopharynx, down to that mouth, okay? The back of the throat. So that's eustachian tube runs that way. And so when you're that age group, 6 to 36 months, your eustachian tube is shorter, it is wider, and it is straighter. And that is ideal for creepy crawlies, right? They don't have a lot of resistance, okay? As the kid grows up, the eustachian tube becomes longer, more narrow. So it's harder for creepy crawlies to work its way up. So what happens when a kid with upper respiratory infection, that's what it stands for, URI, is that you have edema and you're extra snotty. And so with all those factors in place, it almost serves as like a vacuum. And so it can actually kind of suck up those creepy crawlies up into that middle ear. And then again, the middle ear, it's dark, it's wet, it's warm. Who likes that? Of course, your creepy crawly. So we just got all kinds of whammies going on right there with that ear. So upper respiratory infections, those can cause it again because they're snotty. We create that nice vacuum. Kids with a lot of allergies, same reason. They have a lot of allergies, producing all that extra phlegm. We have an issue there. Smoking in the home, that can actually cause it. My son used to get terrible ear infections once a year, and they would always ask me, is there smoking in the home? I'm like, no, there's no smoking in the home. So that's one of the questions they will ask you. So the creepy crawly that will usually cause these ear infections is strep pneumoniae and Haemophilus influenzae. Those are usually the culprits. If we look at this baby right here, poor baby. So,
Can you go back for 1 second?
oops.
Okay, you're fine.
So let's look at this little baby. So otitis media, it does hurt, guys. I don't know if anybody's ever had an ear infection or even just fluid behind their ear. You know that's just aggravating and can be very painful. And so younger babies are not going to really pull at their ears. That what they may do instead is when they're laying in the crib, they may roll their head back and forth, just trying to take care of that pressure. They know it doesn't feel right, but when they roll this way, it kind of feels a little bit better. They have a decreased appetite, and when they are sucking on a bottle, it actually hurts worse because of the pressure. So you may try to give that baby a bottle and they actually are hollering and screaming more because that pressure hurts worse. So they might have a decreased appetite. May have diarrhea and vomiting as well. May have some lymph node enlargement. I already said that, sucking aggravates pain. And fever is common. And the younger they are, the higher their fever is going to spike. So my son was probably about 7 months old with the first one. And he was like 103.6. And I knew right away that's what it was. It was a ear infection. As they get older, the last one he had, he was about 7 years old. Like his temp only ran like 99.6. So that baby is going to spike high. Okay. They're irritable, of course. They cry out at night because if you were to lay them down, especially in a prone position, if you do that, you're not supposed to, but if you do, the pressure will make it worse. So I have here, this little baby's got discharge on his ear. If that pressure builds up high enough, that tympanic membrane will actually rupture. And you'll see some discharge, not as much as this, but you will see some. And it's like the baby feels better. And that makes perfect sense because that pressure has been relieved. So if you feel like if it's an ear infection, you see the discharge and the baby feels better, then that tympanic membrane has already ruptured. And that can lead to hearing loss. So we don't want it to rupture, okay? If you were to examine the baby's ear with a scope, that tympanic membrane is going to be mad. It's going to be red and it's going to be bulging. Very, very mad. What it should look like, it should be pearly, gray, and smooth. That's what it should look like. With otitis media, it's mad. Okay. Treatment, if it's an uncomplicated case, the first time your child's had it, they're going to do antibiotics, of course. Amoxicillin, Augmentin is usually the first round of drugs they go for. They'll be on these medicines for about 10 days. And make sure the parents, caregivers know they need to take it all of it, right? We can do Tylenol for the fever and for the pain, because they will run, like I said, a high fever. The younger the child, the higher the fever. And let's see, I was going to say something. Education. It was very frustrating for me because my son would get them every single year. And so I kept saying, he's going to outgrow this. He's going to outgrow this. Because, like I said, as they get older, that eustachian tube will grow longer and more narrow. And so the anatomy kind of fixes itself. And knock on wood, he hasn't had one in a couple of years. So I'm hoping he's done with them. So hoping. So make sure you tell them that. Other education, no smoking in the home. Make sure you do get their vaccinations because there are a couple that will help cover to prevent otitis media. Okay. The H-influenza, for example, we already talked about that. No propping bottles. This is Ms. Fink's biggest pet peeve with parents. And y'all know what I'm talking about. I've been guilty of it too, where you lay the child in a you put a blanket kind of right here. So be a parent, will actually hold the baby and feed the baby. And but what happens when you prop that bottle, it facilitates ear drainage and you have stasis. And so if you think about the formula, it is warm, it's got a lot of nutrients, glucose especially, and who likes those? Who likes all that glucose? Yeah, they love it. So we don't want to prop our bottles. Let's see. Oh, other education, how to administer meds. A lot of times it will be PO meds, but some parents, kids don't want to take their meds. You have to hold them down. At least that's what I do. But you got to make sure they know how to administer medications, exactly how much to give. And a couple of times when I went to go pick up my medications at Walgreens, it was wrong. They had given me, I can't help you out. No, I can't. Give me a minute. Like 5 minutes. Sorry. So I had picked it up from CVS or Walgreens, and they actually did not give me enough. And so I had to call back. So I know about medications because I'm a nurse. But what about a parent who didn't know that, who just thought, oh, I just needed this much, you know? That's scary to me. But anyway, that's beside the point. But how to administer meds, it could be PO, or sometimes they can actually do drops. So we got to make sure they know actually how to give the medications. I think that's it there. Make sure. Okay, so I got the first one I have the tubes in their ears. So not every kid is going to be a candidate for tubes in their ears, right? Going back to my son, he was not. He would get them once a year, so he was never a candidate. The kids who get ear infections frequently, and I'm talking about the ones who, as soon as they stop taking the antibiotic, like a week later, they're sick again. Those are the kids that need tubes in their ears, okay? And they want to get these tubes in their ears before flu season, cold and flu season starts. So they want to be proactive. They want to prevent these ear infections. So before cold and flu season starts, they will go in and make a little incision, teeny tiny, and then they'll put these little tubes in their ears, allow for drainage. They usually fall out on their own in about a year. Some are earlier, some are later, but about a year. But ideally, it wants to get them through that cold and flu season. Okay, and kids do really well with these. This surgery is quicker than the cataract surgery. I'm talking about 5 minutes. They are in that recovery room, and I'm like hearing screaming kids waking up. So very, very quick, very, very easy, and it works. It's pretty good. So, all right, guys, come back. Oh gosh, how much more do I got? Come back at 11:15. I don't want to run out of time. So 11:15.
Okay.
Stop sharing. All righty. So the next little bit, we're going to be talking about neurological problems. Spina bifida and CP is what is your exemplars are on your competency list. So there's 3 types: spina bifida occulta, meningocele, and then there's myelomeningocele. I'll switch over here so you guys can see the difference. Go ahead and mute yourself, guys. So the first one is spina bifida occulta. So for that one, guys, if you look at the picture, you can see that the spinal cord has failed to fuse. You can see that big gap there. So cord, vertebra. Let's see that. Vertebra. Fuse. And then, but it's nice and we do have that dimpling right there, but there's no herniation. So the skin's intact. We just might have that little dimpling, okay? The second one with meningocele, so we got vertebrae, failed to fuse. We have the herniation, as you can see, the nice bulb right here. So we have herniation. We have this sac right here. You'll have meninges in the sac. Meninges and cerebral spinal fluid. You'll have that in the sac. But that's all you'll have. You'll just have the fluid. Okay? So we see that our spinal cord or the nerves are still running along where it's supposed to. Okay? The last one, the myelomeningocele. So again, we'll have the vertebrae didn't fuse. the herniation, the sac, with the meninges and the cerebral spinal fluid. And we'll just do this. And they'll also have the nerve root.
Miss Atkinson, you're freezing.
That help when can you just not can you get off your iPad? You can work on the word search, but don't upload or download anything, okay? Well, don't do it. Just stop. He never wants to do work, and all of a sudden he just wants to. Okay. Let's see. All right, so here's another picture. So this is the myelomeningocele. So we have the herniation, the sac, and we have the nerve roots that are inside the sac, okay? Just another picture. Just another picture of the various sizes. And then assessment-wise, so they actually can draw what's called an AFP, which is the alpha fetal protein. That is actually produced by the fetus's liver. So they actually can draw that level. And so with spina bifida, the AFP is increased. Okay. And this test particular is optional. It's usually they don't mandate that. You'll have to sign a consent for it. Really, it's not something they generally do. They will offer it always, but not every mom decides to do that. You will see that dimpling. I showed you guys that dimpling on that first slide. You might see a tuft of hair, mass, or sinus tract along that back. Okay. Always assess degree of sensation at or below the level of the lesion. So, they might have some sensation issues. So we got to figure out where they can feel, what they can move. They might have a neurogenic, if I can spell, neurogenic bladder, bowel as well. That's a possibility.
Yeah. Neurogenic bladder and bowel. What does that mean? Does that mean they have incontinence of the bowel and bladder?
They have trouble controlling it, so they might not be able to empty it or pass it completely. So they might have to be catheterized or given enemas and stuff like that for their bowel. Okay, so they're having difficulty or full inability to pass urine or bowels. So these kids are also at risk for hydrocephalus, which that's a fancy way of saying that there's water on the brain. So we're talking about cerebral spinal fluid that can be around the brain. So that can be an issue too. So these kids might have to get shunts in their head to help drain that excess fluid. So treatment, guys.
Hey, could you go back for just 1 second? Okay, thank you.
Mm-hmm. So treatment, these babies are going to have surgery very early on, usually in the first 2 days. They'll have surgery to hopefully correct everything, okay? So monitor for cerebral spinal fluid leakage, and that's usually, hold on, I'll get there in a minute. So when they're born, you need to get as nurse interventions, get a sterile saline soap gauze. I have towels here, but usually they use like bigger gauze and place it on the sac itself because we want to keep that sac clean and sterile as possible. We want to make sure to keep it urine and feces from contaminating that area. We also want to place that infant prone with the hips slightly flexed and legs abducted, because we want to minimize tension on that sac. We don't want to put extra pressure on that sac. Okay, and that makes sense, right? So when I talk about monitoring cerebral spinal fluid leakage, sometimes it might kind of, when it leaks on the pillow, or leaks on a gauze or something, it'll be kind of a circle. Look, it looks yellowish. You might not know what it is exactly. Sometimes they can test it, see whether or not it's a cerebral spinal fluid. But if you suspect that it is, just let the provider know, okay? Frequent calves, bowel programs for home management because of the neurogenic bladder or bowel. Coarse, high fiber, and adequate fluids. Lots of team members are involved. They're going to need lots of physical therapy. These kids, as they grow older, braces, wheelchairs, canes, walkers, whatever they need. So physical therapy, occupational therapy, they all need to be involved. Also have on here neuro, ortho, urology, nurses, teachers are involved, school nurses are involved. Lots of people in these kids' life, and that's a good thing. That's a good thing. Teaching at home, cathing, range of motions. Symptoms of ICP. ICP is increased cranial pressure. So these are the kids that have an extra cerebral spinal fluid around that brain. So for babies, watch out for drowsiness. Their soft spot, you guys know I'm talking about the soft spot. It might be bulging, might be vomiting. For your older kids, headache, seizure, and lethargy, okay? Like I said, these kids will probably have braces on their legs. Braces are risk for skin breakdown, so we need to tell these caregivers, please look under these braces, make sure they're not having any kind of skin breakdown, okay? And these kids are also high risk for latex allergy because they are exposed early and often. Catheters, guys, are latex, okay? You can get a silicone catheter, but they're not readily supplied on a unit. You actually have to call down usually to the OR and get a silicone catheter. Standard catheters are always latex. So if these kids are getting cath as a baby, then my kids are being loud. Then they're exposed early and they're exposed often, okay? So CP, 4 types. We have spastic, dyskinetic, ataxic, and mixed. It affects the central nervous system and it alters the movement. Causes could be trauma, anoxic episodes, infection, or during or after birth. There's a time limit. So before birth, during birth, during labor, something like that, or even after birth. So if the baby is not breathing for a long time, or the baby gets stuck, or the umbilical cord's wrapped around, whatever, that can be an anoxic episode and that can cause cerebral palsy. Okay, so lots of different things can happen during that process, and you guys already know that. Seizures can accompany kids with cerebral palsy. Have altered speech, problems swallowing, vision and hearing, vision and hearing deficits as well. So it's more than just the altered movement and posture. It can be other things, and we'll talk about that. So spastic, we have spasticity or hypertonicity, scissoring of legs. So with these kids, they have their leg muscles and their hip muscles are pretty much all the time flexed, okay? So, hold on 1 second. I can hear you. Can you please be quiet? Go to your room if you want to make those noises. I'm so sorry, guys. Y'all about to see an ugly side of me. All right. So their hip muscles, their leg muscles are pretty much always flexed. So if you were to stand this kid up, like if you were to pick him up off the floor his leg muscles and hip muscles are so flexed that his legs will scissor across, and so they'll scissor like that. Okay. And will certainly, he can't walk like that. He can't walk if his legs are scissored like that. So that's when they'll do braces and things like that. So the second type is dyskinetic, and I have worm-like motions of the extremities and affects the entire body. So they have worm-like motions of their face and mouth. So this makes it, especially for, well, I'm gonna say for babies, but even as they're growing up, it makes it hard for them. Difficulty sucking on a bottle, swallowing, again, and even talking. So a lot of these kids with dyskinetic CP will have a feeding tube. Okay, so a lot of times they're NPO, can't have anything out. Their arms and their legs even have the worm-like extremities. So a lot of times, so you got this kid here, he's kind of got, his arms are kind of wrapped, or I'm gonna say restrained to his wheelchair, because even the arms are kind of moving worm-like, okay? It makes it very difficult to stand, makes it very difficult for them to walk, to sit even. So he's got restraint on the upper chest and even the lower chest, because sitting could even be a problem. Okay.
Ms. Atkinson?
Mm-hmm.
I have a friend, her son, he developed cerebral palsy like during childbirth because he lost so much oxygen. Mm-hmm. And she like sued the hospital and got like a lot of money for that. Yeah. This was a long time ago. He's about like 15 now, but he does not speak, he can't walk, nothing. Like, so he's really bad.
Did you say it was the dyskinetic type, or what type of CP?
Let me see. I think so. Like, he kind of looks like the child in this slide right here. Yeah.
Well, lots can happen at childbirth. You guys know that. When y'all get in the next unit, you will figure out lots can happen. And unfortunately, it does. It's sad, but it does. Mm-hmm. So with ataxic CP, so these kids will have problems with balance and coordination. Okay. And I knew a kid that had ataxic CP, and I can't remember which leg it was, but one leg just did not work. It's kind of like the legs did not talk to each other. Mm-hmm. And so when he walked in a circle, because it was like it just didn't. All the muscle fibers didn't fire like he wanted them to. So he walked in the circle a lot of times. So that's problems with balance and coordination. So treatment, so I have increased calorie intake. So if you think about the spastic one where the legs are flexed all the time, how much calories is he burning? A lot, right? Think about the dyskinetic kid. When he's constantly having that worm-like movement, how much calories does he burn an hour? Mm-hmm. Probably a lot. So we got to make sure they're getting their calorie intake in. Safety, of course, since they have problems with movement and coordination, we worry about them falling and getting hurt. So safety is a big issue. With the dyskinetic type, we worry about aspiration, of course. So safety is a huge thing. Communication board or computer with these kids, again, lots and lots of interdisciplinary care, OT, PT, speech. Everybody's going to be involved with these kids again. Adaptive feeding equipment, and of course, physical therapy. So as they grow up, when we see in the hospital, for me, because I'm kind of one side in the hospital, I just see acute care patients. I do think about them when they go home and stuff like that, but think about these kids. So you take care of a 6-year-old now, but in 6 months, he's going to be probably an inch taller. He's going to need new braces, right? So, I mean, there are some that do extend as you get taller, but that's just, anyway, they do grow. And so they do need to get more adaptive equipment. Mm-hmm. Medications, baclofen. Baclofen is a muscle relaxer and an antispastic agent. It works really well. So these kids, with the spastic with the flexed and the warm light movements, so we want them not to move so much. So baclofen certainly will help with the muscle relaxer, or as for the muscles to relax. So here's a little pump they actually can put in, and it's a little catheter that feeds into the spine. So it's called an intrathecal route. They'll put baclofen in this pouch, and the doctor will set the medicine, the amount, whatnot, so that can help the child instead of having to take it so many times a day. Baclofen is usually every 3 times a day or 4 times a day. And so that's a lot for a child. So that way it's one less thing they have to take. They may need, like I said, seizures can be a problem. So they may need some kind of anti-seizure medication. They may need some benzodiazepine just to help with the brain control or muscle control. We don't want to sedate these kids. They are kids, right? Let them be kids. So we're not trying to sedate them. We're trying to help them to live. Okay. So ADD, ADHD, this term changes back and forth. Last time I checked, we were just saying ADD with or without hyperactivity. That's why I kind of just grouped them together. Manifestations: easily distracted, difficulty waiting turns, excessive talking, leaves uncompleted tasks to begin another, does not appear to listen, squirming, fidgeting, decreased attention span, impulsiveness, often loses things. To me, that is every child you've ever met in your life. However, you got to say a 6-year-old should be able to sit in their seat, right? They shouldn't have to squirm. Or a 6-year-old should have an attention span of about, that varies, but should have an attention span of like 10 to 15 minutes. They shouldn't lose things. So that's what you can kind of say. You relate to where they are on the developmental level to what they should be able to do. But I can tell you both my kids are pretty much all of these things. And also sleep disturbances. That can be an issue too. Okay. How do you get ADD or ADHD? Well, they're not really sure. Some people say it's genetics. Some people say it's the environment. Some people say it's lead or mercury exposure. I don't know, just different things out there. Some people say it's maternal ETOH and tobacco use when she was pregnant, different things. So supportive treatments, this is not necessarily the latest and the greatest, but this is what your book talks about. Decreased stimulation, quiet learn environment, promote self-esteem, reward programs, and parental support. So parental support, guys, I'm also going to put sibling support, because I feel like sometimes when you have a child with a chronic illness, the siblings also can get neglected. So if I have, like, for example, I'm going to use my son has never been diagnosed with ADD or ADHD, but he has a hard time sitting down doing his work. It's a different environment. He struggles. And I have to be with him when he does his work. My daughter, on the other hand, does not. She's very independent, can do her own thing. But she'll come in there and she'll say, Mama, I wish you would help me sometimes. And I'm thinking, gosh, I wish I could too. But you do your work. He does not. So it's like I'm punishing her because he doesn't do his work. So I'm going to throw in there sibling support too. Different medications out there, guys. There's a lot of newer ones. Some of the older ones, of course, Ritalin, Concerta, Adderall. Those are some of your older ones. There's a patch out there. I think it starts with A. Oh, I have it written in my notes. That's a patch that releases medication over like a 9-hour period. The thing about these medications, though, let's say my kid, I put him on Ritalin. He might have did great, right? Or I felt it didn't work. So they're like, let's try Concerta, and then Concerta didn't really work either. It made him like a zombie. And some of these medications do make these kids like a zombie. We don't want to make them a zombie. They're kids. We want them to just be able to focus to learn. So a lot of times in the beginning, they're switching medications up because of the side effects. Okay. And some of the side effects can be loss of appetite, weight loss. If you put them on the wrong medicine and too much, they can almost be like a zombie. You know, it's like they change personalities. We don't want that. We don't want them to change personalities. We just want them to be a kid, but to be able to sit in school and learn. That's what we want. So we don't want to sedate them, right? That's not a real medical term, guys. Zombie is not. I'm just trying to make my point. You won't find that in your Davis Drug Guide anywhere. I'm just trying to get a point across. So autism spectrum disorder, it's a developmental disorder, can affect social interaction, communication, verbal and nonverbal communication. It affects behaviors and interests as well. So different theories on this too, you know, why does my kid have autism, yada, yada, yada. Different theories, again, maybe genetics, maybe a rubella infection.
Some people say vaccine.
Yep. Rubella infection in mom, vaccinations. I don't believe that. That's my opinion. Don't go quoting me anywhere. All my kids, they're all vaccinated. Okay.
Mine too.
I know that's out there. So when are these kids diagnosed? A lot of times it is school age because they're at home with caregivers before they start school, right? And then they start school and they have to sit down, they have to listen to the teacher. And so the teachers are starting to pick up on these things, right? So the caregivers might not necessarily know there's anything different about their kid or the verbal, nonverbal communication. They think, oh, he's younger, he's a boy, he doesn't usually talk that much anyway. But then you get him in school and the teachers start kind of picking up on these things. So with that being said, many times they will get tested or get referred when they're about school aged. So, 6 to 11. 11 is definitely later to get diagnosed, but I'm just saying school age. Although you will start showing signs and symptoms even younger, so about even 18 to 24 months. I know my kid's pediatrician, they will start screening kids about 18 months old about autism. And it's like a little checklist. Yes or no question. Does your child do this? So if you answer yes to anything, the pediatrician would just explore more. So it's just a quick little checklist they'll do. All right. And I say 11 here, but I know a kid that was just diagnosed with autism when he was 13. That's definitely late. But he's straight A, get 5s on his EOGs. His is the interaction, the verbal and nonverbal. Ooh, what is that? Can I please mute? So I have notes on this. I'm not going to go through each one. The only thing I wanted to point out really is that the Rett syndrome, which is rare, but almost exclusively only affects girls. So that's interesting. Typically ADD, ADHD, autism usually affects boys more than girls, but this particular one usually only affects girls. That's all. You guys can watch this on your own time. So manifestations, this interest in holding. So not necessarily a baby, of course, because this starts kind of like toddler age. So when you go maybe try to give your toddler a hug, they'll kind of stiffen up, or they might try to avoid being hugged or cuddled, possibly. Avoids eye contact, poor language development, minimal facial responses. It appears that they may be deaf. So like you're talking to them or you're calling their name and they're not looking at you or they're not answering you. So you're thinking, oh, do they have a hearing problem? Possibly, right? Abnormal activities such as head banging. And if that's the case, if they're doing head banging, safety is an issue. So we may need to make sure they're sitting on soft cushions or even a helmet maybe. No social play. A lot of times they'll have rituals, and that if you break the ritual, they can get very upset. Smiling, you know, they don't really smile a whole lot. Let's just say no smiling. Okay. And guys, a lot of times when people, you know, with autism, it depends on, it's a spectrum. So we can have low to high because it's a spectrum, right? So talking about that kid that was diagnosed at 13, you know, he does have autism. He does not do well in social situations. Super, super smart. So, and then you might have some who may not have a really high IQ. Every kid is not going to fit in one mold when it comes to autism. So I can't say, oh, he has autism, this is what we're going to do for this kid. No, that might work for this kid, but it's not going to work for this kid kind of thing. So just remember that, okay? Not every kid is going to fit in a mold. So treatment, make sure they're in a safe environment. So we talked about the head banging. Decreased stimuli. So it's possible that these kids respond to a lot of noises and lights. If that's the case, then make sure you know, you limit that. I know a kid that could not go to a restaurant. He did okay with lights and people, but it was like the noises of a restaurant, like the low conversations over here, and sometimes the banging of dishes and glasses and stuff like that. He just didn't do well with that noise. So anyway, parental support. Again, you know, parents can reach that breaking point. So make sure we have parental support, and I'm gonna throw in sibling support too. Maintaining routine. We talked about the rituals, that if you break a ritual, they can become very upset. And it could be something like, I read a book recently where the kid only ate a certain type of Go-Gurt. And they changed the label on the Go-Gurt, and his mom bought the same type of Go-Gurt, but it was a different label, and he had a meltdown, and it took her a while to convince him it was the same. But anyway, just examples.
Ms. Atkinson, real quick, sorry. The Rett syndrome, is that like a kind of like, okay, I know it's geared to females. Is that kind of like the autism of females, or that's just something?
No. It's just
okay. Got you. Okay, I feel you. Thanks.
There's no cure for autism, but again, we got interdisciplinary teams involved, right? Going to school, teachers are involved, school nurses involved, school psychologists involved. We got tons of people involved, right? We don't want to sedate. You know, I'm gonna just say this: least restrictive. Meaning, you know, if they're doing the head banging, things like that, you know, we want to keep them safe. We don't want to restrain them necessarily. We don't want to sedate them necessarily. Again, they're kids, right? So I'm going to say least restrictive. Although my mom worked with special needs kids for a long, long time, and occasionally she would have to restrain them. She hated it. She had this whole big write-up when she did restrain them. But and it's body restraint. It's not restraints in the hospital, like she's on top of them. But occasionally she did have to do that. Like I said, she hated it. She didn't like it. Nobody liked it. Had to call the police. It's all a big mess. So, all right. So, GI health problems. So we'll talk about failure to thrive, intussusception, and Hirschsprung's. So failure to thrive, there are two types. There's organic and there's non-organic. So with organic, there's something physical is going on. So it could be GERD. It could be something with the heart. I mean, it could be cystic fibrosis, something, right? Something physical. We can test, we can do diagnostic tests and figure out what's going on. And with non-organic, we're looking at psychosocial. So could it be neglect? Could it be knowledge deficit? A lot of times it is, right? You never had a baby. You don't have support. You're young. I mean, it could be certainly be knowledge deficit. It can be money, right? It could be stress. I mean, that list can go on and on, right? So, if it's whichever type it is, organic versus non-organic, we need to figure out what it is and we need to fix it because that's what nurses do, right? We fix things. We want to anyway. But failure to thrive, guys, the definition of it is they fall below 5th percentile on weight chart. And I'll show you that chart in just a minute. So here, I'll show it to you real quick. So this is that pretty chart. I'm sure you guys with kids or working in peds, you guys have seen this many, many times. So as the baby, whenever your child goes into the doctor's office, they weigh, they take their height, they do their head for the baby, and they'll put them on a chart. And so this middle line right here, that's 50%. You know, kids can hover somewhere in or about. My kid, Seth, is 50% for his weight and 25% for his height. But you can't see it on here, but around here, there's like a 5th percentile. So these failure to thrive kids are falling below that 5th percentile. So they're falling below one of these lines. Okay, I don't know. Okay, my daughter is in the 5th percentile of her weight. She is teeny tiny, but she's always been that way. So he's not concerned. He's not concerned she's failure to thrive. Okay. But these kids, all of a sudden, if they're sitting at 25%, 30% of their weight, and they come in and they dropped, we got a problem, right? Mm-hmm. So this picture was in my maternal book and when I was in nursing school. I don't know which culture. I don't know anything. I don't remember the culture or anything about it. But what I do remember is that this baby that's nursing, these are twins. This baby's nursing is a male. This baby getting this bottle is a female. So going back to that non-organic cause of failure to thrive, is it culture related? Something to consider, right? That's always kind of, I remember that picture from my book a long time ago. All right. Manifestations, weight, again, they're going to fall below that 5th percentile. Can have a delay in developmental milestones, so they're not meeting those milestones. So they're not sitting up, they're not crawling, they're not, reaching for objects, they're not tracking, whatever it is, whatever they're supposed to be doing, they're not meeting those milestones. Decreased muscle mass, they can have abdominal distension, muscular hypotonia, and generalized weakness and cachexia. Cachexia is like severe malnutrition. They're actually wasting. In a picture that goes in my mind when I think about wasting as I think of concentration camps, those pictures. Mm-hmm. Okay. Here's that chart. I wish we could see it, but I can't. But y'all get the idea. So behavioral indicators. So avoidance of eye contact. So these babies, these younger kids, they actually show show apathy. They're very irritable. I mean, for good reason too. Sometimes even though as the kid gets older, they can show extreme compliance because they want to eat. They're hungry. They figured if I'm a good kid, if I do this, then I'll get food, right? So compliance. Intense watchfulness. What do you think that reminds me of? Anybody? Think of Erickson.
Trust versus mistrust.
Trust versus mistrust. So if they're really watching you, do you think they trust their caregiver? That just reminds me of that. Difficulty to soothe, sleep disturbances, disturbed manner, repetitive motions. So this could be rocking back and forth. This could be head banging. This could be like intense sucking their hands, fingers. Chewing their hands, fingers, whatnot. And head rolling back and forth. So those are just examples of some repetitive motions, okay? Treatment. So Failure to Thrive, it's a big deal. We do want our kids to grow. So that's why it's important that they do go see their primary and when they're babies, they should go at least once a month. And then after that, they'll go once a year just to make sure that they are growing the way they're supposed to grow. So if they have to be hospitalized as a nurse, we're definitely going to do in output, right? Yes, always. We're documenting their eating patterns. There usually is, when I work peds for a very short time, there is an order. I'm not kidding you. The doctor will write an order for the nurse to be in the room to watch the parent or the caregiver feed that child. We will watch them make the formula, mix it up, give it to the child, make sure they're documenting the right way, because that's what they're going to do when they get home. So we're actually watching all of this take place, okay? Make sure you let the caregivers know that you as a nurse, we feed on demand and we increase the intake, high protein, high calorie, frequent small portions of a wide variety. So if it's GERD or whatnot, of course, we're going to need like a PPI or an H2 blocker for that. If it's heart issues, we need to treat that. But psychosocial, like if it's money, guys, please contact the social worker. In those programs that give them free formula, free food, okay? Please contact the social worker. And a lot of times it might be education. Formula is very, very expensive. My daughter was on formula like 6 months on. My son was never on formula. I saved a lot of money with him, but it's very expensive, especially if they have allergies. So if you're getting that more expensive formula and they're drinking, parents might be watering it down to make it last.
Stretch.
Please make sure there's education. Please make sure you provide them with those resources, okay? If it's a depression issue, domestic violence issue, something like that, please contact someone they can get psychological help, okay? Don't just say, oh, you need to get better. Oh, no, you make sure it gets done. You make sure you get this, that you get those consults for those caregivers, okay? We don't want any babies falling through the cracks, right? Or children. All right, intussusception. So this happens, that was a quick segue, wasn't it? So this one happens when the intestine prolapse into, or let's see, and then it telescopes into another part. So if you look at this normal bowel, and then you look at this intussusception, so it kind of prolapse and it kind of folds into itself. Do you see how it's kind of like going inside? Mm-hmm. That's what happens with intussusception. It kind of telescopes inside itself, and that's not good. It does not like it. Your intestines does not like it when that happens. So it's inflamed, right? We know it's mad. So we have edema. We have decreased blood flow. And then what happens when we have decreased blood flow?
Will that area eventually die out?
Yeah, necrosis.
Necrosis, yeah.
We don't want that, right? Mm-hmm. So we don't want that to happen. So we want to intervene before that. It's caused by, believe it or not, it's caused by a virus. Okay. So assessment. So usually in the very, very beginning, the stool is brown. There's nothing going on really. And then as as the pain increases, so does intussusception. So if the child is really starting to complain of their stomach, it's from there, it's just going to get worse. Okay. So the kid, will kind of be like in a fetal position with their legs drawn up, trying to release some of that pain. They're crying. I mean, it's painful. So I have acute pain with nausea, vomiting. And then as the condition gets worse, their stools will look like red currant jelly. Okay, that's why I have that here. You will also sometimes feel a mass in the upper right quad or mid-upper. So you could feel a mass. You can palpate his abdomen and feel that mass, potentially. And it usually happens to kids younger than 2, 3. Okay, so like I said, initially, it may start to prolapse and telescope, but normal stool, kid feels okay. But as they feel the pain getting worse and worse, that disease is progressing. So you will have the progressive symptoms: the red currant jelly, stool, the mass, the severe pain with nausea, vomiting. So one good thing about intussusception is that about 90%, 70 to 90% cases are fixed with a contrast barium enema. That's easy fix, isn't it? I would have never, whoever thought of this is a genius, but what it is when they do the contrast barium enema, the pressure exerted on the intestine by the enema will actually cause that intestine just to kind of full out. So the pressure just kind of makes it come on out. It's a beautiful thing, right? Easy, done. NG tube could be an option. Of course, for the NG tube, we're just doing decompression. Okay. If those two things do not work, then they're going to do surgery. Okay. And with the surgery, if it's necrotic, they'll remove that necrotic tissue. If it's not, they'll just kind of correct itself and then go forth. Okay. So that's good. The enema usually works. The bad thing is that it can be a reoccurrence. Okay. So let the parents know they can be a reoccurrence, that if their child starts showing the symptoms again, to bring them in immediately. Okay. All right. Hirschsprung's. Oh, I did want to say, okay, I'll say that in a minute. Hold on. So Hirschsprung's is known as megacolon and congenital aganglionosis. So this picture is not a kid picture. This is an adult, but this adult had megacolon. Look at this thing. Y'all. Yeah. This was actually from a student. A student gave me this who worked in the OR and wanted to know if I wanted a picture. I'm like, yes. So again, it's not a kid, but still, I was still floored. Like, how can you carry that in your abdomen? Oh my gosh, I couldn't even imagine. All right. So with Hirschsprung's, it is believed that it's congenital, so that you are born with it. It's more common in males or males. And the most common site is going to be this, the rectosigmoid colon through here, most common site. All right, so what happens with Hirschsprung's disease? So if you look at this word aganglionosis, so what do you think that means? Y'all know what that means?
No ganglion cells.
Mm-hmm. So A, of course, means no or without, right? I'm going to say absence, though. Absence of the ganglion cells. Okay. And so those ganglion cells in our intestines, they are responsible for, what's that P word that our bowels do? Not poop. Peristalsis, right. And so if we don't have those ganglion cells in this portion, for the picture right here, we're not having the peristalsis, right? We have that lack of nerve innervation.
So the poop just kind of stuck there.
Yep, exhibit So the poop where in here, if you look right here, it's very pencil thin. Do you see that?
Yeah.
It's very pencil thin. So
is that how the poop's gonna look when it does come out? Real pencil thin?
It will be pencil thin. If it comes out, it'll be pencil thin. Correct.
Because you're pretty constipated.
Oh yes.
Okay.
All right. So newborn. The biggest thing with newborns is they do not have their first meconial stool. So meconium is baby, and you'll hear it like if you watch certain medical term, they'll call it mech. They'll say mech stools, which is meconium stools, which is baby's first poop. And those who have babies, y'all know what it looks like. It's very black and tar, icky. I have never had a change in my kids' meconium poops. My husband's always did it, but when I did my peds rotation or OB, I did mess with mech some. So, but it's very black, tarry, and sticky. So that's first telltale is that if when the newborn baby does not pass that first stool, then they start looking into, could it possibly be Hirschsprung's? Okay. I had a really good nurse friend. Her baby was born 2 weeks before my first baby. And her son had to stay longer because they thought he had Hirschsprung's. And they did biopsies on his colon and all kinds of stuff. It turns out it was not. But anyway, reluctant to ingest fluids, abdominal distension, and some vomit. For infants, failure to thrive, we have constipation, and then it can turn into diarrhea. It can kind of go back and forth, constipation, diarrhea, abdominal distension, vomiting, fecal impaction, and then, like we said before, the pencil thin stools. You can look at that, go back and look at that picture. So I will tell you guys, because I love you, is that you've got to know the difference for sure between intussusception and Hirschsprung's. Okay. That's probably not spelled right, but that's okay. You get what I'm saying. Treatment, they have to do surgery. Okay. So they'll go in and they'll take out the part of the colon that does not have the nerve innervation. So they'll remove the aganglionic bowel. Aganglionic bowel. They remove that. The kid will have a colostomy. And then hopefully later on when things heal, they can come back in and do a takedown. That's the plan. They'll reverse the colostomy. Okay. So post-op wise, if you're taking care of this kid, post-op wise, of course, the kid's going to be NPO. He's going to have an NG tube with low intermittent wall suction. You know, you guys are monitoring his bowel sounds, making sure he's having bowel sounds. He's passing gas. When he goes home, go home with the colostomy. So we got to teach the caregivers on how to care for a colostomy. What is the stoma supposed to look like?
You being red.
Mm-hmm. Bright red.
Yep, it needs to be red. It shouldn't be dusky in color. If that's the case, then it's not getting blood flow, right? Mm-hmm. It shouldn't be dry. So lots of teaching with the colostomy. And you guys have had that when you did integrity. So I'm not going to go into all of that. All right, Down syndrome. Oh, it's trisomy 21. So 21 is your chromosome. So you know you get 23. You get half from your dad. You get half from your mom, and so it should be 2 of each thing, right? 2 of those chromosomes. Well, with Down syndrome, you have 3 number 21s. Okay, so 3 of them. That's what trisomy means. You have 3 of the number 21s. Okay. Assessment, flattened occiput, that's the back of the head, that's flattened. Depressed nasal bridge, slant of the eyes, they'll have epicanthal folds, brush fill spots, like little specklings on their iris. Protrusion of the tongue, they have low set ears. Part of your newborn assessment, which you guys will get hopefully soon, is that when you assess that newborn, you will actually check the symmetry between their eyes and their ears. Okay. And then kids with Down syndrome, they'll have low set ears. You check the symmetry of that, the ears will be lower. And then simian line, have the example there for you guys to see. You might have some kids with Down syndrome might have some mental disabilities. Every case is different. I can't put all kids in one mold and say this is what's going to happen. I can't do that. So some have some mental disabilities, some might be severe, some may not be severe at all, right? The AFP, we talked about AFP when we talked about spina bifida. We said with spina bifida, it can be increased, but with Down syndrome, it actually can be decreased. So to me, since we've got this crazy test, we've already mentioned it twice, you know, how accurate can it be? You know, I think that's up in the air. Treatment depends on the severity. Again, what does the kid need? Do they need speech therapy, occupational therapy, physical therapy? If so, get them that kind of therapy. A lot of times these also have skin issues, so they're going to need a skin specialist, dermatologist. They can have GI problems, so let's make sure they have help with that. They can have orthodontic conditions, so let's make sure they get help with that. So again, what does that kid need? Whatever they need, then you make sure that consult is appropriate for that kid. Okay. All right, we'll do cystic fibrosis and we'll take a quick break because I don't want to leave you guys hanging. So cystic fibrosis, I have notes for you. So it's the decreased chloride secretion, increased sodium absorption. And so because of this imbalance, you'll have thick, sticky mucus. It clogs the lungs and puts them at risk for infections, obstructs the pancreas, so you can't digest well. It also affects the reproductive system. So for males, the obstruction will occur in the vas deferens, and then for females, they have thick cervical mucus, and that can lead to infertility, okay, which makes sense. If we talked about the cervical mucus having to be appropriate for sperm anyway. So if this we have thick cervical mucus, we can see why that would cause infertility. Have on here that kids will get like a respiratory virus, and kids who don't have cystic fibrosis, you know, they will get over that cold relatively quick and easy. But kids with cystic fibrosis, because they have that extra sticky mucus, it gets stuck. That can lead to bacterial pneumonia, and they don't usually recover as quickly. Cough is very classic cough. I don't know if you know anybody with cystic fibrosis, but it's very congested type cough. Air becomes trapped, leading to hyperinflation, atelectasis, secondary respiratory infections. So let me show you guys this real quick. So do y'all remember Punnett Square from microbiology? You're thinking about it?
Yeah. Yes,
right.
I do.
You do? Alicia said yes. All right. So we said that cystic fibrosis is a autosomal recessive disorder, meaning both parents have to have it for the child to get it. So let's say this is me. Oh Lord, that's not what I want to do. Stop it. That's gonna mess me up. I just want to, I don't want that. Oh gosh, do it. All right, I'm not gonna be able to do it. Sorry, I don't want to waste your time. But if you look at the square, if you guys remember how to do it, so it's an autosomal recessive disorder. So let's say I have to carry the trait and my husband has to carry the trait. And we have a 25% chance of one of our kids getting cystic fibrosis. Because if you, like I said, look up Punnett square. I wish I can show you how to do it right now, and I don't want to waste your time trying to figure out how to do it. But basically, when you do the Punnett square, you'll see one in 4 kids have a possibility of getting cystic fibrosis because both parents carry that trait. Okay, and that's what that means. Recessive. So it's not a dominant trait; it's a recessive trait. All right. So assessment: salty to taste. They can have meconium ileus. Their stool has steatorrhea, which means it's like fat or greasy stool. Frothy, and it's very foul smelling. They can have constipation, chronic moist cough, frequent respiratory infections, and difficulty gaining weight. So with that being said, sometimes they're short in stature. And it affects their growth, obviously, right? They're dealing with this since day one as a baby. So short in stature, they can have a delayed onset of puberty as well. So treatment, maintain respiratory function. So what does that look like? Well, lots of things. They can have daily meds, nebulizers. They can have inhalers. Very important for them to do chest PT. Where they bang on their chest. There's cool machines that you can wrap around their chest, turn the machine on, and kind of like gets out that, breaks up that mucus for them so they can cough it out. Let's see. Manage infections. So again, they can get just a regular cold that can lead to pneumonia. So we want to get that treated early as possible. So we're antibiotics. A lot of times these kids, as they get older, they will actually become resistant to some of their medications that they used to take. They can't take the penicillins anymore. They're like in the big boy antibiotics, okay? Manage infections, vaccinations. These kids will definitely need their vaccinations. We want to prevent as much as possible. Let's see. Sometimes lungs collapse, so they might need a chest tube. That's a possibility. Lung transplant. That's a possibility. There was one in Cabarrus County, probably in the last 4 years, that just got a lung transplant. But lots of different medications, lots of different treatment for them. Promote optimal nutrition and exercise. So these kids, they are burning a lot of calories, right? So we want them to eat a lot of calories. So we're talking about 100 to 120, 150% more than recommended daily value. So we're eating more, okay? They also need to take a pancreatic enzyme. This will help with digestion. So they need to take this enzyme every time they eat. So if they're eating breakfast, they need to take it. If they're eating a snack, they need to take their enzyme. So every time they eat, okay? We got to make sure they're growing. So we're definitely going to be weighing them. What else? Oh, they need to eat lots of salt. Okay, because when they do sweat more, they excrete more salt. So we don't want them to become hyponatremic. So we want them to eat lots and lots of salt. Okay. GERD can be an issue with them, so we want to treat the GERD. We don't want them. GERD can aggravate lung function, so we don't want that to happen. So we're going to treat the GERD. Also, too, because we are blocking the pancreas, diabetes can be an issue. So we're going to make sure we're treating that. This can be very hard to treat diabetes because they're eating so much food. So we gotta have that nice balance for them. This video is just kid getting chest. I think it's a kid. It might be an older kid, but getting chest physical therapy. It's just an example. You guys can watch that later. All right, let's take a quick break. Y'all come back at 12:25 and we'll finish up, okay? Okay, let's get finished. Record. All right. So developmental dysplasia. So for these new, wash machine's loud. So the femoral head and the acetabulum are improperly aligned when we talk about developmental dysplasia. So there's 4 types. There's instability, which basically with that one is that the is loose. So that hip joint is loose. The second type is dislocation, where it's completely out of the socket. And then the third type, the subluxation, it's partially dislocated. And the fourth one is acetabular dysplasia. So when we think of dysplasia, you think of abnormal cells. Some say abnormal cellular or structural development. So when these babies are born, I've said newborn assessment like 5 times now, but this is part of the newborn assessment. When the babies are born, if you see this picture right here, they fix their fingers on that hip right there, and they will take the legs and they will kind of go like in a circle, out and in, out and in. And with their fingers, they're feeling for popping, they're feeling whether or not that joint is out. And so they will do this with the newborn assessment, and they will do this to the baby every time you take them to the provider for a well child visit once a month. They will do this until that child is walking. They want to make sure that hip is staying in that joint. So finally, this one will affect girls more than boys. And the reason is because estrogen from the mom actually causes that hip joint or those ligaments to kind of be loose anyway. And girls respond to the estrogen more than the boys. So that's why. It's usually just one leg, so it's unilateral. And it's usually the left. And that's because the position of the baby in the uterus. So usually the left. Being breached can cause it, of course. That makes sense. So yeah, so it affects girls because of the estrogen. So assessment, when you do your newborn assessment, you'll have limited abduction. You'll have asymmetry of the gluteal and thigh folds. If you look at this baby right here, cute little butt. If you look at this baby, and if you think about somebody that has a hip fracture, a regular person has hip fracture, you know that their leg is shorter, right, and externally rotated. So if you look at this baby right here, the leg that has more of the folds, because their leg is being pistoned in, so they'll have more of the folds there. So it's shorter. And if it's untreated as a baby, then they'll have a limp as an older child. So that's why it's important to get these babies screened. So treatment. So if they're younger than 3 months, they will put them in a harness. And so if you look at this harness right here, this Pavlik harness, these legs are abducted and they are flexed. Okay, that's what we want. If they are older than 6 months, they will do close reduction, and they'll put them in a spica cast. And so look at this little spica cast. It has a little area for bowel and bladder. So there you go. And of course, these legs, they put them in a certain position too. If they're older and they're walking, then they'll have to do an open reduction. And we don't want that. We'd rather catch them when they're younger than 3 months, and we can just put them in this harness, okay? They usually do very well though. If they're found and treated early, they do great. So vaccination schedule, guys, I have copies on your Blackboard. You can't really see this, so please pull up the Blackboard CDC links. That is on your test. I will tell you that.
Go back for just 1 sec.
The harness.
Okay, thank you.
All right, lead poisoning. You don't see a whole lot of lead poisoning anymore because we've kind of taken that away as the years gone by. However, the average serum level, if we were to draw our levels, it'll be about 0.6 micrograms per deciliter, which is good news because in the 1970s, those who were alive in the 1970s, the average lead level was about 15 micrograms per deciliter. Okay, so we definitely got better. Hold on 1 second. Let me turn this up. So we definitely got better since the 1970s. So my brothers both were born in the 70s, and I always talk about their lead exposure, but just a joke. However, no, there is no safe level. So even though we're 0.6 now, it's still not safe. It's tended to be in older homes. The clients tend to be poorer. The common source is lead paint. We can ingest it from contaminated foods, water, or soil, and it can be inhaled through dust. Okay. So every once in a while, you hear news about foreign toys that have lead in them. For the toys for kids have lead in them. Some makeup, even you might hear some crazy stories about makeup having lead in it. So just kind of know where your stuff comes from and know what's in it, right? So it can interfere with normal cell function. And I got nervous system, blood cells, and kidneys. It can adversely affect the metabolism of vitamin D and calcium. And then the manifestation is going to depend on your level. So I have your different levels here. So 10 to 14, we can have mild impairment in growth, fine motor skills, and anemia. Think about this little chart right here, guys. So as we increase 20 to 44, so we can have impairment of growth, fine motor skills, and anemia, plus fatigue, difficulty, concentration, paresis, headache. So all of these symptoms can still be included as we increase, okay? So anemia can be increased, or it will be throughout. Motor skills will be throughout, okay? So don't think that that stops at that level. So over 70, encephalopathy, death, and seizure. So it's a big deal. We don't take lead poisoning lightly, okay? So treatment, there's a thing called chelation therapy. They should be admitted to a monitor bed because chelation can affect the heart rhythm. But what it does is it's injected, and it will bind to the lead, and it'll help excrete it through the kidneys. So it's a good thing. Before the kid goes home, make sure that the home is lead free. So what does this mean? We got to figure out where the lead source is coming from. Is it the paint? Is it the toys? Is it, the dust in the home? Is it the soil he plays in? So we got to make sure it's a lead-free home. So wet mopping or wet dusting. So I'm not talking about getting a feather dust and dust your home. I'm talking about get a washcloth or something, wet it, and, clean your window sills and your baseboards and all those things. Because if you just use a feather duster, you're just pushing it back into the air. So if you wet it, it actually stays on your wet cloth, and that's what we want. Wash the kids' hands before they eat. Like if they're playing outside and it's in the soil, make sure their hands are clean so they're not ingesting it that way. Make sure you're washing their toys, their pacifiers, all that is really well. And you can actually get your home tested for lead. Where is the source coming from? Enriched iron and calcium diet. So lead can keep these from being absorbed. So we want to make sure they're eating more. Also, we want them to eat frequently. So frequent intervals. Because when their stomach is empty, that's when they can absorb the lead more. So we want them to eat to keep their stomach full. Okay. Education, follow repeated testing. So part of education, if you do live in an older home, if you're going to renovate it and you know it's an older home, then let kids go stay with grandma for a while you renovate, while you're breaking all the walls down, while you're peeling off the paint. So let them go stay with somebody else during that renovation, okay? And also education is teach them signs and symptoms of lead poisoning, you know. Very important. All right, abuse and neglect. I have notes for you guys here. This YouTube video is about a guy. He wrote a series of books called A Boy Called It. And it's just him being interviewed, and it's absolutely awful. So get some tissues before you even read the book. But I do have notes here for you. I have physical abuse, physical neglect, emotional abuse, emotional neglect, and sexual abuse. Physical abuse is pretty easy. Something done to the body, pain or injury. Physical neglect is you're not meeting those basic needs, right? Nutrition, shelter, clothing, even going to the doctor, that's considered neglect. You know, those kids need to go to the doctor for a well child visit. Emotional abuse, shaming, ridiculing, destroying a child's property, calling them names. Emotional neglect, emotional unavailability to the child. And I feel like I'm doing this to my daughter because I spent all day on my computer, then I help my son do his work, and then where's my daughter at? So I'm having to make sure I spend extra time with her so I don't emotionally neglect her and she turns into a serial killer, right? Just kidding. And then sexual abuse, we know what that is, okay? Factors increasing risk for physical abuse, self-explanatory, age less than 3 years. I thought that was pretty significant, which makes sense though, because somebody can talk better, it may be more vocal. Child disability. So if a child cannot talk at all, and this happens to older adults too, it's sad. But anyway, clinical manifestations of physical abuse. I think that's pretty self-explanatory. We have multiple bruises, fractures, old and new. These clear demarcation lines. So one picture that sticks in my mind is a baby being dropped into a boiling pot of water. And come out. So you'll have a clear demarcation line of that abdomen around the belly, and then down would be scalded and burned versus up. That's what I mean by clear demarcation lines, right? Belt marks. Change behavior and performance at school. So a lot of times the teachers will say, I'm not sure what's going on with so-and-so. They're acting out. They're not doing well in school. Physical neglect, stealing food, hoarding, unclean clothes, but also have inappropriate clothing for the season. So if it's snowing outside and ice and they have ratty shorts on, you know, possibly looking at neglect, right? Sexual abuse kids, vaginal discharge, blood-stained underwear, UTIs. Quick story, I took my daughter a long time ago. She was 3 or 4. My son was a baby, and I took her to urgent care. She had really bad GI diarrhea for like 3 days. And then she developed a UTI, which happens a lot after a GI bug because not cleaning good, right? And so I took her to urgent care, and they actually assessed her for sexual abuse. They had me step out of the room and another nurse come in, and I wasn't upset because I thought they were doing their job, but why would a 3-year-old have a UTI? It turns out she didn't have a UTI. She was a little dehydrated, but still, I was a little bit hurt at the same time, but at the same time, I'm like, I'm glad they're doing this, you know. All right, so I have on here, very important, sometimes these cases are difficult to catch or see, right? You're busy. You might not be suspicious of something. If you are, guys, please, please, please follow your chain of command. Usually it's your supervisor. So call your supervisor and say, hey, da-da-da-da, this is what's going on. They will escalate it. They will contact who they need to contact, whether it's the police, Child Protective Services, or whatever. If you don't, guys, then you're responsible for that. You neglected those kids, okay? You could be wrong. They could do a whole investigation and you're wrong, and that's okay. That's okay, but you did your job of escalating it, okay? I'd rather you be wrong about it than you don't say anything at all and then something going on, okay? But you have a duty to protect these kids. And if you don't, and something is going on and your documentation shows it, that you documented these bruises and you documented the burns or whatnot, they can come back and say, well, Tracy, you documented, why didn't you not report? Right?
Why you say my name?
Because I see your face. That's it. But anyway, so you guys are responsible. So risk factors: absence of natural father in the home, being female, mothers outside the home, poor relationship, parental relationship characterized by conflict, parental substance abuse, or social isolation. All right. So anticipatory guidance. I love anticipatory guidance. So this is just education. When you take your child to the pediatrician, they kind of give you advice on what to expect next. So if you bring your 4-month-old into the clinic, they're going to say, oh, by 6 months, they should be sitting up, right? By this age, they should be doing this. So it's kind of like anticipating what you should expect with your child. Also, at the same time, though, they're doing education. So like when my kids hit, really toddler age, they were giving me advice on how to lock up my cabinets so they don't get in the cabinets and get chemicals. As they get older, they talk about gun control, make sure the ammunition and guns are locked up separately, wearing your bike helmets, wearing your car seat, or sitting in your car seats, wearing your seat belts. So they're giving you advice on how to keep your child safe as well, okay, depending on the age. So it's really neat. So now both my kids, they're getting an age that they are gun control, sports safety, car safety, bike safety, and my daughter being a teenager, they're talking to her about sexual activity safety as well. Okay, just anyway. Phases of grief, you guys know what this is. So Kubler-Ross, denial, shock, numbness, y'all know what that is. Anger, they're angry at you, their spouse, whoever, they're angry. Bargaining, they may bargain with a higher power, asking like the what if questions. What if I do this? Can I do this? They may seek experimental drugs here, possibly. And then depression, and then finally acceptance. And so with Kubler-Ross, you guys know it doesn't follow this nice 1, 2, 3, 4, 5 pattern. It can go to depression, back to angry. It can go back to bargaining, back to denial. So it's not a clear-cut, nice, smooth transition. It's all over the place. So, but the reason why it's in this unit is because phases of grief for the caregivers, I'm going to say parents, caregivers, because if you're born, if your child is born with a chronic condition, like cystic fibrosis or some of the other ones we talked about, autism or whatnot, the parents, the caregivers, they can grieve as well, right? They can grieve over what could have been, what's not going to be. My child has cystic fibrosis, could we ride bikes in the park, or they get really short of breath. So you're grieving over that as well, okay? So remember back in 111, I said you can grieve over anything. You can grieve over a lost shoe, just anything. So, and then of course, national patient safety goals are in this unit too. You guys talked about that earlier too, but I have that link for you as well. All right, let me save this. Stop sharing. I know we have 5 minutes left. So you can leave if you want to, or I can do a review right now. It probably 2 minutes. All right, let me make sure I got my ducks in a row. Hold on.
Yes, review, please.
Please review.
Okay. It's a Kahoot game, so y'all get your phones out or whatnot. Hold on. All right. I think the volume's good. Y'all go ahead and sign in. Everybody about 30 more seconds and we'll start. All right. Right. So Depo is an injection once every 3 months to prevent pregnancy. We talked about it can help out with endometriosis as well. So, and it takes, if you want to become pregnant later on, it could take up to 9 months to be fertile again. So we got to know our audience. Oh, I got to move this picture. Okay. All right. All righty. Yep. So the earliest they can get the flu vaccination is 6 months, and they'll have to actually get 2. They'll get one at 6 months, and they'll get one about a month later. So they cannot get it at birth. They get hepatitis B, the first shot, around that time, usually the next day. Okay. So go back and look at your charts for your vaccinations. Yep, about 14 days before she starts her period. That's when she ovulates. That is when she is fertile. So we want to, if we don't want to get pregnant, then we're going to avoid having intercourse during that time. So So about 14 days before she starts her period. That is true. So right offhand, HPV, of course, and we talked about herpes as well. Very good, Clomid. So intrauterine insemination can work for infertile couples, but it's not a drug, it's a procedure. So I'm glad y'all didn't put that. Baclofen is muscle relaxer, dantrolene, we use that not to get pregnant with. Crazy cat lady. Remember I said you got to know allergies for your AUBs. That's an easy one. So metrorrhagia, metro means in between, right? So that was an easy one. PCOS can cause secondary amenorrhea. So primary amenorrhea is, she's reached 16, she's never had a period. Something's going on, no ovaries, no uterus, something like that's going on. And then secondary amenorrhea is when they're doing fine and then all of a sudden they stop for 3 months. Right. Taking B complex vitamins help. Eating lots of chocolate, no, it's got caffeine in it. We actually want to limit our caffeine intake. And same thing as with alcohol. We want to limit alcohol. And then rest, we want them to exercise. So we don't want them to rest. Exercising helps with those feel good hormones. Correct. Everybody got that right. Good deal. Correct. So that endometrial tissue is growing outside the uterus where it's not supposed to grow. Right. Short stature is correct. So it can cause acne, hirsutism, which is that facial hair, and alopecia. Short stature, when it comes to female problems, you have to worry about with girls with primary amenorrhea, because something's going on, they're lacking certain hormones or whatnot, they can be short stature because they can have that delayed onset of puberty. So PCOS does not cause short stature. That's an easy one. Yep. Not having a period for 12 months. Correct. It has 4 stages. It's got primary, secondary, the latent, and the tertiary. So y'all make sure you go back and look at those stages, what they look like, and treatment. Very good. Tertiary, you're not contagious. Primary and secondary is when you're most contagious. Correct. So primary, the telltale sign is that sore, okay? Secondary, we have the rash with the flu-like symptoms. Correct. Neither one, type 2 or type 1, can be cured. Just treat it. Symptom management. Yep, you need antivirals, and acyclovir is an antiviral. So herpes is a virus, not a bacteria. So antibiotics will not cure it or treat it. You need an antiviral. Correct. It can cause that newborn conjunctivitis. It does not cause endometriosis. It does not cause PCOS. And chlamydia, remember we said gonorrhea and chlamydia are sisters. So gonorrhea does not cause chlamydia, but oftentimes they are found together. Right. It's chlamydia. But just because you PID doesn't mean you have an STI. It could be other organisms, but chlamydia is the one, the most common. Crusty eyes. Yep. Redness, crusty eyes, some drainage. Oh, we need to talk about conductive hair loss. Right, we didn't talk about the different types of hearing loss. So we did say it can cause hearing loss, especially with that tympanic membrane does rupture. It can cause hearing loss. So that's all you need to know for that. I already told y'all this answer. That's cheating. Yes, they'll get their first hepatitis B before they leave the facility. This MMR, measles, mumps, rubella, and varicella, they will not get that until they turn 1, and then they'll get a booster for kindergarten shots. Okay, so I always remember that, because MMR and varicella are like I always think of them like big boy vaccinations. They hurt. So in my mind, you got to be bigger to get this vaccination. So they won't get their first one until they hit a year. That's how
It's on Blackboard, right?
It's a link for it. Yes.
Oh, okay.
Yeah. It's a link from the CDC. Yes, it can cause infertility because of the obstruction of the vas deferens or because of the thick cervical mucus. Mm-hmm. Yep. So organic is something pathos going on. So GERD, heart defect, versus non-organic, something psychosocial is going on, like knowledge deficit. Okay. Oh, we didn't talk about this either, but that's okay. You guys can figure it out. You don't have to know this for the test. Yep. So the most accurate way, and it's supposed to be, I misspelled way. I used the other form of way. But anytime a diaper, when you're doing peds and you're measuring intake and output and you're want to know the most accurate way is weigh that diaper. Okay, so the most accurate one should have been a giveaway. All right, let me stop sharing. Oh, actually, let's see who. Third place is Jordan. Good job, Jordan. Second, Emily. First place. I know who that is. I don't think she wants me to tell her name. And runners up was Erica and Pee Wee. All right. So guys, just like with all my Kahoots, they're not the questions on my test, but if it's the same kind of content. So we talked about syphilis, we talked about herpes, they're going to be on the test. And so if you feel like you don't know that, if you got that question wrong, then go back and look at those things. Okay. That's how I do my Kahoots. So if you're unsure about something, you missed a question, make sure you go back and check those slides out. Okay. Any questions? I know we're over time.
The immunizations, do we need to know like the age that they need to catch up on their immunizations, or do we need to know what's in yellow? That's most important.
So as far, let me get rid of this. Hold on. It is like going on in the background. So for immunizations, it will be mandatory, not optional. Is that what you mean?
No. So on the CDC, it's color coded, and the yellow is the most important. And you have the other colors that are like catching up if you missed a shot. So my question to you is, we need to focus on the yellow instead of the other colors.
Right. So you would need to focus on, let's say a 12-month-old comes in the clinic. What should they probably get? Or a 5-year-old, what should they get? Not catching up, not optional.
Gotcha. Thank you.
Okay. Mm-hmm.
Thank you.
Mm-hmm. And there's math, guys. You know, there's always math, so don't forget your math. Should be pretty straightforward. Okay.
So we focus on what is in the yellow for immunizations.
Yeah. So like I said, it's not going to be optional. Vaccination is not going to be catching up. It's going to be basic. This is what you expect to get when they go to that office at that time period. So a 4-month-old would get these shots. 6-month-old would get these shots.
Okay.
I have a question about the medications that we need to know. For like the herpes, it was the acyclovir, and then in parentheses it says Zofirax. Which one would you want us to know for the test?
So typically on my test, you would have to know the generics.
Okay.
That was hard for me too, Elaine. I ain't gonna lie. And that's how I know it's generic. If I have a hard time pronouncing it, I know it's generic. That's how I keep them straight in my mind. There are some words I can write it and I can't even spell it sometimes, and I can't say it, but you know, we just go with it. I will send an email out or a Blackboard announcement out tomorrow about downloading the test, guys. So look for that. And I don't know, I'm proctoring. I know Miss Walker is proctoring. I don't know who the third one is. So just be looking out for whoever to send the Zoom invite for, okay? So I'm not sure who that third person is. And make sure you download the correct test. There'll be 2 tests. There's just the regular one. There'll be one that says accommodations. So make sure you download your correct test.
So the word Clomid won't be on the test. It'll be the generic word for that.
I typically do generics. Yes.
Okay.
And I'll post these PowerPoints and the recording whenever it downloads to my computer. It takes a while for Zoom to download it to your computer. Mm-hmm. 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 For me,
How is she a teenager now? Oh wow, so she's young. They usually don't typically check that, Elaine, until she hits about 10 or 11. That's the first time they usually check scoliosis. 30. I thought you said 3. Okay, I'm sorry. Yep. And that's something that's her well child assessment. That's something they should check. Like I said, the first time they check it is about 10, 11-ish, 12-ish in there. And then once she hits her second growth spurt in that time period, they'll actually check her again. And so I'm not sure why they didn't check her. I don't know. But I know my son just went last Tuesday for his 11-year-old checkup, and they checked him for scoliosis. So and he got 2 shots. He got his Tdap and he got his meningococcal. And that nurse, whoever she was, not a nurse, she gave both injections in the same arm, and I almost lost it. I had to take a deep breath because she did it so fast. I was moving out of the way so she can get back on his other side, and before I could turn around, she'd already put both those injections in the same deltoid. Yes, I was very mad. I had to walk out, and I called them later when I calmed down because that hurts. The Tdap hurts. I don't know if you guys, if you gotten not the he got the anyway. If you got a tetanus shot or whatnot, that hurts. Y'all know that. And so for him to get 2 injections in the same back arm is just, I just can't believe she did that. So anyway. All right, if y'all are good, please email me with any questions. I pretty much sit at my computer all day. So just send them to me. And I'll see y'all, some of y'all on Wednesday.